We're about to start the next session. Thank you very much, first of all, for all of you who stayed for the last 3 lectures for this afternoon. The 3 lectures that we will be having are about opportunistic infections and HIV-related complications, a typical presentation. Our first lecture will be by Dr. Ploenchan Chetchotsakd. Professor Ploenchan is a professor of medicine at the Division of Infectious Diseases and Tropical Diseases, the Department of Medicine, Faculty of Medicine, KhonKaen University, KhonKaen, Thailand. Her lecture will be about fungal infections. Welcome, Ajahn Ploenchan.
Thank you very much. Good afternoon, ladies and gentlemen. I will spend maybe 20 minutes or so not to give lecture because you have a lot of lecture this morning and the previous speaker. I will start with the case, okay? This is a 40-year-old female. She was diagnosed of HIV positive in 2002. She was contracted from her husband. And on that year, she also have a TB lymph node completely treated. And then after that, we start on antiretroviral treatment, D433TC, nevirapine, or GPOVS. And then after virus suppressed, we change to ACT3TC, nevirapine. And after tenofovir available, we change to tenofovir 3TC and nevirapine. And she doing okay during the first period. You can see her CD4 is very high and virus mostly suppressed until on August 2012, her CD4 dropped and virus go up to 1,600 copies. And the genotype show resistant to NNRTI and 3TC. So her regimen was changed to tenofovir, ACT, and lopinavir. After we changed her regimen, she lost to follow-up. She doesn't want to take a lot of medication, so she lost follow-up for 3 years. And then on 1st of April last year, she was referred back to our hospital for evaluation of brain abscesses. She has a history of 4 weeks prior to admission, developed fever and weight loss of 6 kilograms. And 2 weeks, she developed seizure and then admitted to the local hospital. The CT scan showed that the rim enhancement lesion at the left temporal lobe, right frontal lobe. She was treated as toxoplasmosis with pyrimethamine and sulfadiazine without response. They do the CT scan after 2 weeks and then it's not improved, so why? And the neurosurgeon over there don't want to do the brain biopsy in HIV patients, so why? She was referred to our hospital. Physical examination, she was fully conscious, no neurological deficit, no stiff neck. She has oral thrush and oral hairy leukoplakia. This is a CT scan. It's very small because they send this as a packet, not a CD. This was done on 29th of March. So we did a new CT scan in our hospital. This is a lesion over here, over here, over here, over here. So it's show the multiple well-defined hypodense rim enhancement lesion with perilesional edema at right frontal, left corona radiata, right temporal, left temporal, and right temporal base, and right cerebellar. The radiologist also look at the previous X-ray and impressed that no change from the previous study. Her workup serum cryptoantigen was negative. Toxoplasma IgG was negative. Her CD4 right now is down to 40 cells. And my anemia, BN creatinine normal. Liver function, she has my elevation of liver enzymes. LDH is 247. So I would like to you to vote what is the most likely diagnosis on this patient. If she has toxoplasmosis or tuberculosis because she have is before, or cryptococcosis or histoplasmosis, or the last one is the CNS lymphoma. A few of you vote. Okay, a lot of you said that she has tuberculosis and toxoplasmosis, and the next one is the histoplasmosis. Okay. I'll show you later what is the diagnosis. I would like to know what are you doing during this time to do the lumbar puncture or treat as toxoplasmosis. And follow CT scan or treat at toxoplasmosis and do brain biopsy, and treat her as tuberculosis and brain biopsy, or treat her empirically with toxoplasmosis and tuberculosis together. Okay, most of you do the lumbar puncture. Interesting. And next is the treat at toxoplasmosis. Even she doesn't have she has brain swelling but no midline shift. So I'm quite scared to do the lumbar puncture on her. So we do the choice B. We treat her as toxoplasmosis and then do the brain biopsy. The brain biopsy was done and the PCR for TB was negative, gram stain was negative, everything negative. So she was treated at toxoplasmosis while waiting for brain biopsy result. And we follow her CT later, almost 3 weeks later. Her lesion is improving. You can see here is smaller. The overall finding improvement of multiple brain abscess by evidence of decreasing size and number. I will not vote. I just want to know your thing. Do you think she has toxoplasmosis? Raise your hand if it's yes. Who is think is no? Still some. Okay. This is her brain biopsy. You can see some organism here, several. So we did the GMS. This is the GMS. So she has histoplasmosis. Okay. This is the study, in one study, the prospective antifungal therapy alliance registered in 300 cases of HIV patients. They have overall 320 isolate of fungus. Cryptococcus is the most common. 50%. Candida is the second most common, and histoplasmosis is the third common. This is the median CD4 count of the patient when they present with this invasive fungal infection. And among the histoplasmosis patient, 10% of them has CNS involvement. Histoplasmosis with CNS involvement can be anything. But the most common is the acute or chronic meningitis. And patient can present any other symptoms: stroke, seizure, headache, focal, neurological, hydrocephalus, myelopathy, fever, weight loss, memory loss, cognitive impairment, and absence of extra neurological signs and symptoms. If the patient have meningitis, you can make diagnosis by the CSF culture or meninges or brain biopsy. And another investigation that you can do is the antibody, and in the CSF or serum, and also the CSF antigen and urine or serum antigen. However, these investigations are not available in Thailand. So most of the case we just make diagnosis by scraping of the lesion, biopsy the lesion, and do the culture. Okay, that is the first case thing. I think it's an atypical presentation because the present mimic the toxoplasmosis. Okay, so we go to the second case. He is a 51-year-old male referred to our hospital for treatment of recurrent cryptococcosis. He was diagnosed of HIV infection with cryptococcal meningitis in August 2014. He was treated with amphotericin B with fluconazole 800 milligrams for 2 weeks, and then followed by fluconazole 400 milligrams as a consolidation phase treatment, and then go to 200 milligram maintenance. His CD4 is quite low, for 43 cells. He started on our standard regimen, GPOVS, which is D40, 3TC, and nevirapine. About 8 months later, he developed headache. And at that time, they checked the CD4. His CD4 count is up to 216, and viral suppressed. They said that he has recurrent cryptococcal meningitis. So they treat him again with the amphotericin B, fluconazole 800 milligrams. The induction phase, the same, but they increase the consolidation to 800 milligrams, and then continue fluconazole 800 milligrams. However, about that is on March, and then August, 5 months later, he developed headache again. And then this time he referred to our hospital. We did the lumbar puncture. Pressure is not very high, 24 centimeter water, protein 47, sugar is slightly low, 37, and white blood cell is just only 1 cell, India ink positive, and the culture grew Cryptococcus neoformans. We check his CD4 is down to 72 cells, and viral load suppressed. This time we also check his hepatitis B surface antigen positive, hepatitis B antibody also positive. So I would like to know what is your thought about the cause of his cryptococcal meningitis. Poor compliance to antifungal drug, or fluconazole resistant strain, or inadequate drug level from drug interaction, or poor immunity from low CD4 count, or E, I don't know. So most of you, because of the previous speaker talking about the inadequate drug-drug interaction, so you think that it might be drug interaction. Okay. We think that it might have drug-resistant cryptococcosis, so we did the fungal sensitivity. You can see here that fluconazole MIC was 32. So he has a resistant strain of fluconazole. So we do the hepatitis B DNA was undetectable. He is quite lucky because he on just only 3TC. Hepatitis C is genotype 3A and viral load is very high, 3 million. And he has persistent increase in intracranial pressure, so the VP shunt was done. So what should you do next? Maintenance treatment with weekly amphotericin B or change to itraconazole or change to voriconazole or posaconazole.
But I would be changing.
Oh. So this is reflect what you have in your country. Also, I think most of the audience choose to maintenance with weekly amphotericin B, and the next is maybe the one who more rich choose to change to voriconazole. This patient is in the universal coverage, so voriconazole is not available. And because maintenance with weekly amphotericin B is problematic, the patient have to come to the hospital every week, so we choose to use itraconazole. But the dose we choose to 600 milligrams. And we also changed his antiretroviral to tenofovir 3TC to treat both hepatitis B and HIV, and maintain nevirapine for his HIV infection. This is the CDC recommendation induction for cryptococcal meningitis. They recommend liposomal amphotericin B plus full-cytosine or amphotericin B deoxycholate and full-cytosine. But in our country and most of the region here, I think we don't have the full-cytosine. So in Thailand, our guideline is in the alternative regimen. So we choose to use the amphotericin B plus fluconazole 800 milligrams for induction for 2 weeks. For consolidation phase, the recommendation to use the fluconazole 400 milligrams, and alternative is itraconazole 200 milligrams BID, which is 400 milligrams. And for the maintenance, the recommendation is just only fluconazole and no listed for alternative regimen. And if you look at the isolate of the crypto, what the drugs that can be used, you can see this study, they did the culture and sensitivity in the two period, 2002 and 2003, and another year is for 2007 and 2008. You can see the MIC for M4 is low, full cytosine also okay, fluconazole is quite high, but it's in susceptible range. Voriconazole, posaconazole, and itraconazole has a quite low MIC. But the recommendation that I show you is based on the study that is a long time ago, 1997. That is if we look at the outcome at 10 weeks of the step 2. The step 1 is the patient with cryptococcal meningitis, HIV patient. They randomized to receive amphotericin B alone or ampho plus 5FC. And then after 2 weeks, complete treatment of 2 weeks, they randomized to receive fluconazole or itraconazole. This is the outcome. If you look at the culture negative here and the clinical response, you can see numerically is higher in fluconazole, but the difference is not statistically significant. But if you do the multivariate in this study, you can see that treatment of fluconazole is associated with the negative CSF culture as 10 weeks. So we know that fluconazole is slightly better than itraconazole. And for maintenance study, this study is the randomized control trial also for HIV patients who have a crypto and receive consolidation treatment until CSF culture negative. They randomized to fluconazole 200 milligram or itras 200 milligram. At that time, antiretroviral is not widely available, you can see. And in this study, the study was stopped by the DSMB because a lot of patients who received itraconazole has culture negative as compared to fluconazole. This is why fluconazole is the recommendation. For voriconazole, there is just only one study, randomized control, but it's a small study. They look at the early fungicidal activity among standard treatment, amphotericin B with 5-FC, M4 with fluconazole 800 milligram, fluconazole 1,200 milligram, and voriconazole 600 milligram for 2 weeks, the induction phase. You can see from here the culture negative or early fungicidal activity are the same among all treatment arms. So come back to our case. So after we changed his antifungal to itraconazole, he come back again with the recurrent headache and vomiting for 3 days. CT scan show my hydrocephalus. We did the lumbar puncture. The pressure is increased, and India ink also positive. The CSF again culture crypto. How to explain this? This is the Ploenchan malfunction, or is a ARV treatment failure, or is resistant to itraconazole, or drug interaction causing low level of itraconazole, or the last one, I don't know. Okay, so most of you said that it's the drug interaction caused low level of itraconazole. This is, so we repeat the fungal sensitivity again, and the itraconazole is the same, very low MIC. So we did the CD4 and viral load. The viral is still suppressed, and then we check we give him another course of amphotericin B with itraconazole 400 milligram with the antiretroviral treatment, the same regimen, and then we check the itraconazole level. The level is just only 0.08 milligram per liter, which is under therapeutic level. So we change him neuropin to lopinavir, and then we check the level again is in 0.73, so it's in therapeutic level. And he received M4 with itraconazole for 30 days and then discharged. And this is a culture negative before discharge him. So you are right. before I have this patient, I don't aware about the drug interaction. Actually, this study was done by Ajahn Suthep in Thailand, in Songkla he did the PK study. This is the in normal patient to receive itraconazole administration alone or combination with nevirapine. You can see here, this is the itraconazole blood level. But when you co-administer with the nevirapine, the blood level is reduced significantly. And there are also the report case of itraconazole and efavirenz with the histoplasmosis. The patient, they follow the urine histo level. And you can see here the urine antigen is persistent, even the virus is suppressed. But when they change the efavirenz to atazanavir, the urine antigen is go down to 0.6. So there is some case report. This is my last slide to remind you about most of you, I think, still working with HIV patient with opportunistic infection. When you need to use the itraconazole, you have to beware of drug interaction. Nevirapine and itraconazole do not co-administer. The quality of evidence is high because it's decreased the Cmax 38% and AUC 61%. For efavirenz and itraconazole is potentially interaction. Cmax is decreased 37%, AUC 39%. So they suggest to use other drug. If you cannot use, you have to monitor blood level. Okay. Thank you very much for your attention.
Thank you very much, Ajahn Ploenchan. Any questions from the audience? I have a question.
Yes.
I was just wondering, what's the prognosis for the histoplasmosis case and the drug-resistant crypto case? Since that they are atypical presentations, does it change?
May you repeat the question again?
I would like to know the prognosis for these cases. Does it change because they presented atypically?
Prognosis?
Yes.
Prognosis in this patient?
Yes.
He received the treatment right now. He just come back for follow-up. He's doing better. Everything is fine. But he gone through several courses of relapse and received the treatment.
Okay.
Yes.
Any other questions? If not, then we'll go to the next lecture. Oh, there's a question.
Thank you so much for the presentation. Just a question about the antiretroviral. If we cannot use nevirapine and efavirenz, if there is any other alternative eventually that can be used in your experience. Thank you so much.
Okay. Protease inhibitor, you can be used with itraconazole. Yes. Lopinavir or atazanavir is okay.
Okay. Thank you very much, Ajahn Ploenchan. Our next speaker is Dr. Sasisopin Kiertiburanakul. She is an immunologist, virologist, and microbiologist. She is an associate professor at the division and head of the Division of Infectious Diseases, Department of Medicine, Faculty of Medicine, Ramathibodi Hospital, Mahidol University. She She has worked in the field of HIV for 15 years and has been principal investigator and co-investigators in many international multi-center studies and authored numerous publications. Welcome, Dr. Sasisopin.
So thank you very much for your very kind introductions. Good afternoon, ladies and gentlemen. So I'm really excited to speak after my mentor, Dr. Ploenchan. So I try to do my best. I'm going to talk about bacterial infections. This is my disclosure. I would like to talk about an overview of bacterial infections, which is still common now, actually in developing countries. I will focus on bacterial respiratory tract infections and gastrointestinal infections, and I will close with my case presentation. First of all, I would like to begin with my question. So I would like you to guess that what is the most common cause of bacterial infection in HIV-infected patients. Choice is Staph aureus, Strep pneumo, Salmonella, E. coli, and Pseudomonas aeruginosa. I think next time it's going to be 15 seconds is enough, I think. Otherwise you need more music. Okay, most of you answer Strep pneumo, followed by Salmonella. So I will not give the answer now, and you will give the answer. You will know the answer at the end of my talk. So you may recognize that this is the 1993 AIDS defining conditions. You can see that we have two bacterial infections, which is put in the AIDS defining illness. So the first one is recurrent pneumonia, and the second one is recurrent Salmonella septicemia. If you see the patient with recurrent pneumonia and septicemia of Salmonella, it means that the patient have very advanced disease or AIDS. This is the data like a long time ago before hard era. This is the data in Africa. They collect the data of bacteremia and fungemia in HIV patients who admitted to the hospital during pre-hard era. You can see that the total bacteremia is about 20 to 25%, and the most common bacteria is non-typhoidal Salmonella, followed by Strep pneumo. And you compared to crypto is less here. Crypto is less than 10%. And the mortality over there is about some study high up to 60%. This is a study that I did in my hospital. I would like to know what is the cause of the bloodstream infection in HIV-infected patients in Thailand during the hard era. So I did the retrospective study during the 2004 and 2008. We include 140 patients. The mean age is about 40, and the CD4 is very low, it's only 32. 90% is community-acquired infections, and the mortality rate is 21. So this is the picture shows the distribution of the culture. The most common cause of bacteremia is gram-negative, 40%, followed by fungus, 24%, and mycobacteria is 20%, and the last one is gram-positive. The table shows the focal size of infection. The most common is a central nervous system. Means that the cryptococcal infection is the most common in this study. This is a distribution of the causative pathogen. You can see that the most common pathogen is fungal, is a cryptococcal neoformans, and the second one is the Salmonella infection. Sorry. And followed by tuberculosis, and another one is E. coli. And you can see for the bacteria is Salmonella, the first rank, and followed by E. coli, Staph aureus, Klebsiella pneumoniae, and Strep pneumo is very low proportion. So I would like to move to focus on bacterial respiratory tract disease. So the most common disease for the respiratory tract disease in HIV-infected patients is sinusitis, bronchitis, otitis media, and pneumonia. This is the most common infection complication in HIV patients. They can occur in every CD4 cell count, and bacterial pneumonia may occur with the increased severity. So the incidence of bacterial pneumonia in HIV patient is greater than non-HIV infection, especially in pre-HAART era. But right now in the HAART era, the incidence of bacterial pneumonia has been declined. And some patients, some HIV patients may come to the hospital with bacterial pneumonia, which is the first manifestations, and it can occur in any stage of HIV disease and at any CD4 cell count. What is the factor? What is the risk factor of HIV patient who develop bacterial pneumonia? There are many reasons, such as they have B cell defects, also impaired neutrophil functions or number. Actually, the patient have a very low CD4 cell count. Actually, in our region here, in developing country, that most of the patients who come to the hospital with very late presentations, and most of the patients who come with in the hospital, they have no antiretroviral therapy. And also another factor that, for everyone, like cigarette smoking, injection drug use, also chronic viral hepatitis. This is the cause of bacterial pneumonia in HIV infection, which is quite the same as non-HIV infection. But with the star, you can see this is some pathogen that's quite more common in HIV-infected patients, such as strep pneumo, Haemophilus influenza, Staph aureus, and Pseudomonas aeruginosa. This is the data about the invasive pneumococcal disease in normal patients compared to the patient who have underlying disease as well as HIV infections. This is a incidence rate of the patient who have invasive pneumococcal disease. If any underlying disease is quite low, and you compare to any underlying disease, and the HIV is the last one, and you can see that HIV. This is the data from England. The HIV infection is quite a risk factor for developing invasive pneumococcal disease. But you can notice that this is like the study in 2008, which some patients may not get the antiretroviral therapy. But the more recent data, data show that if the patient receives antiretroviral therapy, the incidence of pneumococcal disease is very low compared to the patient who did not receive antiretroviral therapy. You can see the graph here. And if the patient has a high CD4, you can see the incidence of pneumococcal disease is very low as well. And you can see that here. When the patient have more than 500 CD4 cell counts, the incidence is very low compared to the patient who had a CD4 less than 200, even not receive antiretroviral therapy or receive antiretroviral therapy. Right now, we are in the HAART era. Some doctors say that HIV patient may not the risk factor for strep pneumo, but some patients still have another risk factor that's as the same as non-HIV patient, right? We have a HIV patient who have older, right? 60, 70, which is the risk factor for strep pneumo infections. Some patients may have still have a very low CD4 cell count. Some may not taking antiretroviral therapy. They have alcohol drinking. They have injection drug use. They have they're still smoking. So this is all the risk factor that is another, besides HIV infection, this is cause invasive pneumococcal disease. For bacterial pneumonia, especially in Thailand or developing country, sometimes you may have to differentiate it from another infections, lung infections such as tuberculosis and PCP. And some patients have a risk factor for Pseudomonas aeruginosa infection they have to think about, or Staph aureus infections such as they have infection or pneumonia post-influenza infection, or they have a history of IDU. So you have to think about Staph aureus or another of Pseudomonas aeruginosa. For the treatment of bacterial pneumonia in HIV-infected patients, normally we use the same criteria or the same criteria to assess community-acquired pneumonia disease as in non-HIV infected patients. And they have some principles for the treatment of community-acquired pneumonia in HIV-infected patients. Overall, it's the same. The principle is the same. We have to choose antibiotics and give promptly without waiting the culture results. But in case of that patient receive macrolide for MAC prophylaxis, they should not prescribe macrolide monotherapy. And also, if you are not sure about tuberculosis in that case, you don't prescribe fluoroquinolone as an empirical therapy. In that case, you need to use with caution. Actually, in Thailand, we have a lot of patients who come with like acute community-acquired pneumonia, but it turned out to be tuberculosis. So this is the treatment of CAP, which is the same as the guideline. So I will skip this. You can see in the guideline. So let's talk about the prevention of bacterial pneumonia. So we have vaccine, right? We have vaccine, like we have Step pneumo vaccine. The patient, in HIV patient, you need to recommend influenza for the patients. We need antiretroviral therapy to raise the CD4, and if the patient have high CD4, they have less likely to get the bacterial pneumonia. About lifestyle modifications such as quit smoking, no alcohol drinking. And for the patient who has a low CD4, we give a prophylaxis for PCP, right? The Bactrim prophylaxis or MAC prophylaxis has been shown to be associated with the risk of bacterial pneumonia. But we don't recommend to give any antibiotic for primary prophylaxis specifically for that pneumonia. But if you give Bactrim for the general recommendation, is fine. So HIP vaccine is not usually recommended in HIV-infected patients. So let's move to the bacterial enteric infections. The incidence of gram-negative bacterial infection is higher, about tenfold in HIV-infected patients. But right now, the rate is declined after we have the patient start antiretroviral therapy. But the risk of bacterial diarrhea still, especially the patient have CD4 less than 200. And the most common one is Salmonella, followed by Shigella and Campylobacter. Sometimes we have Clostridium difficile-associated infection in HIV-infected patients. So what is the source? What is the factor of gastrointestinal tract infection in HIV patients? So sometimes they have ingestion of contaminated food and water. About sexual activity, about MSM, they do fecal, they may get fecal oral exposure. Classic acrohydria or HIV-associated alternations of mucosal immunities, and some patients get the acid suppression agents. So there are three major clinical syndromes of the gastrointestinal tract infection of the gram-negative. The first one is he or she may get only gastroenteritis and just self-limit. The second form is more severe and prolonged diarrhea, such as fever, bloody diarrhea, weight loss, or possible bacteremia. And the last one, like septicemia. They can present like extra-intestinal involvement with or without gastrointestinal illness. So let's talk about a little bit about Salmonella, which is the most common gram-negative or most common bacterial infection in HIV-infected patients. So there is a clear association between HIV infection and non-typhoidal Salmonella. And some cases they got a severe disease. The clinical presentations of Salmonella may be just only gastroenteritis, or sometimes they have a bacteremia such as fever, chill, and leukocytosis. For the history, for the diagnosis of bacterial gastrointestinal tract infection, for the history you have to get the exposure history, the medical review such as antibiotics, because that I told you that some patients may get C. diff infections, the quantification of diarrheal disease, the associated signs and symptoms. For the workup, laboratory workup, you can do stool culture, blood cultures, All HIV-infected patients present with diarrhea and fever, you should do blood culture as well. But some organisms you may need to talk to microbiology lab because we need some special culture such as Campylobacter or Helicobacter that need some special culture. So exam for C. difficile toxin, and in some cases we need endoscopy. The treatment, like the general, you need like the hydration, diet, and for the probiotic and anti-inflammatory, there is not adequate data in HIV-infected patients. For antibiotics, it depends on CD4 cell count of the patient and severity of diarrhea. Normally, we empirical with ceftriaxone, cefotaxime, ciprofloxacin, or clotamoxazole. For treatment of Salmonella, in general population, if the patient comes with Salmonella gastroenteritis, we do not treat them. But for HIV patient, we normally recommend antibiotic for treat Salmonella in HIV patients. The recommendation from the MMWR guideline, they recommend ciprofloxacin for Salmonella gastroenteritis with or without bacteremia. The alternative is levofloxacin or moxifloxacin followed by clotamoxazole. But anyway, for drug recommendation, you need to check with the susceptibility of your country, of your hospital, because it varies from hospital to hospital. For example, this is the data of susceptibility of Salmonella in Bangkok. This is data from Sirirat Hospital. They collect almost 700 of 28 isolated, almost 70% from feces and 24% from blood. And this is mixed between HIV and non-HIV. You can see that the most drug that have almost 95% sensitivity is ciprofloxacin. So it means that ciprofloxacin can be used in Thailand. We use ceftriaxone a lot in Thailand, but you can see that ceftriaxone is only 67%. So you may have some isolated of Salmonella that resist to cephalosporin. This is the data from my hospital, Ramathibodi, and you can see that ciprofloxacin is only 45%. So if you empiric with cipro, you may maybe lost more than half of the patients. But in contrast, the sensitive to amoxicillin clownate is like 90%. So it depends on hospital to hospital. For the treatment duration of for salmonellosis, it depends on CD4 cell count and the patient have bacteremia or not. So this is a guideline or suggestion from MMWR. So if the patient have no bacteremia, you may the patient have CD4 more than 200, you may treat 7 to 14 days. But if the patient have very low CD4 cell count, you may to treat longer, like maybe up to 6 weeks. And if the patient have bacteremia, at least 14 days, if the CD4 more than 200, and maybe up to 6 weeks if the patient have CD4 less than 200. For exposure prevention, there is no primary prophylaxis to prevent Salmonella. So we need to recommend the patient to do hand washing after contact or potential contact to human feces animal. Also washing the hand before and after sex, and use the protective barrier during sex, and try to avoid the uncooked food or unpasteurized dairy product, and avoid or minimize to contact with reptile, sheep or duck that may be the source of Salmonella. So this is my conclusion before I end with my case. So bacterial infection is still common in HIV patient. Actually, the patient have very low CD4 cell count and do not get any antiretroviral therapy. Recurrent pneumonia and Salmonella are age-defining conditions. So we need to think about an early diagnosis, and treatment of bacterial infection may decrease morbidity and mortality, and also the prevention issue. So let's go with my case. He's 35 years old, labor, live in Bangkok. He came to the hospital with 10 days of low-grade fever, low back pain, radiated to left hip, and no trauma before. He was diagnosed AIDS about 10 years ago. He has history of cryptococcal meningitis and received the treatment. He is still on antiretroviral therapy. In the previous, he received a D4T TC efavirenz and now changed to tenofovir 3TC and efavirenz. He still takes fluconazole prophylaxis after cryptococcal meningitis and also received cotrimoxazole for PCP prophylaxis. The laboratory, the last test is 3 months prior, CD4 is 102 and virus less than 40. He has heterosexual risk, no IDU. He has DM, diabetes, poor control. He has hypertension, hyperlipidemia, and hypothyroid. So the physical examination, the temperature is 37. He had alert, lipoatrophy from D40, leukocytic, mild pale, no lymph node, heart, lung normal. For abdomen, soft but mild tender at left middle and lower quadrant, normal liver span, just palpable spleen, splenic dullness positive. He also had back pain when around CVA, costal vertebral ankle area on the left than right, so as sign negative, neuroclastic intact. He still had PPE on both legs. So lab show leukocytosis to 20,000, high sugar because of his uncontrolled diabetes, and a little bit abnormal liver function test. This is a plain film for chest X-ray. It looks quite normal. This is a plain abdomen. So let's see, let's guess what is the diagnosis in this patient. So he has very low CD4, but suppressed viral load, come with 10-day fever with low back pain. He has psoas abscess, splenic abscess, osteomyelitis, acute pyelonephritis, or I don't like the choice, so you may tell me what is the choice that you need to answer. Okay, so most of you think about psoas abscess followed by splenic abscess because he have a myasplenomegaly. So this is a CT abdomen because he also have abdominal pain and have low back pain, so we don't know exactly what is abnormal in his abdomen. You see something abnormal from CT? So I will ask you what is the organism. So I will talk to you what is this is abnormal. You see here? And here. This is an aortic aneurysm, about 5 centimeters here. Splenomegaly, but no mass, just only abdominal aortic aneurysm. So what do you think, what is the cause? What is the organism that causes aortic aneurysm in this case? Staph aureus, strep group B, we saw some Salmonella, Klebsiella pneumoniae, or E. coli. Some may think about because they have he has diabetes, maybe Klebsiella pneumoniae. Okay, most of you choose Salmonella followed by E. coli. So let's see the answer. So before I go to the answer, what antibiotic that you want to give to this patient? Ceftriaxone, which we use a lot in Thailand, or we need higher antibiotics, just molopinam or Cipro, that you think is enough for Salmonella in Thailand, or amoxicillin clarinate, or ceftriaxone plus metronidazole. Okay, is like balanced distribution. So, but 5 give me ceftriaxone followed by Cipro, amoxicillin clavonate. So in this patient, at the first day that he come to the hospital, the doctor gives ceftriaxone. This is a common that cover both gram-negative and gram-negative infection. But the culture come back, Salmonella group C with resistance to ceftriaxone that I told you the data from SIRA that 30% is resistant to ceftriaxone. They're sensitive to amoxicillin clavonate, also Cipro. So 3 days later, when we got the results of culture, we changed ceftriaxone to Cipro. And then we go surgery to do operation, aortic interposition graft. Finding is concealed rupture of myocardial aneurysm of infrarenal aorta. The operation time is 3 hours and 20 minutes, but unfortunately, the patient died after operation, just 2 hours, maybe recurrent rupture of aneurysm. But I just show you like another case report show about the Salmonella myocardial aneurysm that we see some in some case report. And right now, this is the data from Chulalongkorn Hospital. They report the case that right now we have the endovascular aneurysm repair or EVA, that like the closed operation that we don't need to do open operation. We put the graft into the vessel, and the outcome is very good. The doctor of Chulalongkorn Hospital, they report 2 cases of HIV with very low CD4 cell count and do endovascular aneurysm repair. And it was successful in these 2 cases. So I'd like to finish my talk, and thank you very much for your attention. Thank you.
Thank you very much. Any questions from the audience? Okay. No questions. Thank you very much, Dr.
Okay, thank you.
Our next speaker is Dr. Irini Sereti. Dr. Sereti is the chief of the HIV pathogenesis section and is a laboratory of immunoregulation of the National Institutes of Health. Her primary research focus is the study of inflammation in HIV infection in the form of immune reconstitution inflammatory syndrome, which is the topic of her talk today. Welcome, Dr. Sereti.
Okay, thank you very much. Am I supposed to press the red or for the questions? I'm sorry. Yes. F10. And then that will F10. Where's the 10? Oh, function 10. Oh, okay, I see. I'm sorry. This one or this? This? Or just alone?
And then that will have the...
Okay. Okay, thank you. All right. So thank you for inviting me in this session. I think it's wonderful and has been very informative to see the previous talks. So I'm going to focus my presentation on a very specific syndrome that is seen in conjunction with initiation of antiretroviral therapy in HIV-infected patients, usually with advanced disease, which is called IRIS, or immune reconstitution inflammatory syndrome. And I'll try to go quickly through the presentation so that we can get to discuss some of the cases that I have at the end, which are all real cases that I have seen in the clinic and the hospital. So the outline of the talk is we will briefly discuss the phenomenon of immune reconstitution inflammatory syndrome, specifically for HIV infection, discussing a few of the opportunistic infections that it has been associated with, also touch upon prevention and treatment, and then we're going to move on to case presentations. Oops, sorry. Okay, so I just wanted to start by showing this mortality data that actually come from San Francisco and are showing here that survival in patients who present with an opportunistic disease in HIV infection has really dramatically improved since the introduction of combination antiretroviral therapy. The really depressing line here at the bottom shows really prior to combination antiretroviral therapy. This one that also doesn't look so well is the monodual antiretroviral therapy. And this is really the success of combination antiretroviral therapy. But the thing that I really want to highlight is that we're talking about success in patients who have an AIDS-defining disease that in San Francisco is, we know, the survival in the 60% range. So really there's a lot more to be done, and I think Dr. Nidaya also showed some data from Thailand yesterday showing that although the CD4 count at diagnosis has slightly improved over the last few years, mortality remains pretty high in people who present with advanced disease. So I think discussing opportunistic infections and immune reconstitution syndrome is still very relevant, particularly in settings like this one. So what do we mean by saying immune reconstitution inflammatory syndrome? And unfortunately, it's still pretty much a syndromic definition. So it takes a lot of wording and a lot of seeing and a lot of believing sometimes. So we're describing this syndrome, we're trying to, what we're seeing really is a worsening of the manifestations, and I say of manifestations and not of the actual disease, or abrupt atypical presentation of an infection. Sometimes it could be a malignancy, particularly Kaposi sarcoma, when HIV patients start antiretroviral therapy. It comes in two flavors. We call it paradoxical, where the infection or the tumor was known. So a patient with tuberculosis starts TB treatment, improves, starts antiretroviral therapy, symptoms get worse. Or unmasking, when the infection was actually unknown or not diagnosed prior to antiretroviral therapy initiation, but the assumption is that it was present, it was subclinical and occult, and it sort of becomes clinically overt when antiretroviral therapy is initiated. The incidence really can vary greatly between 7% and 50% in different studies, depending on the underlying population, as well as the prevalence of different infections in a particular area. But for the most part, it's seen within the first 6 months of antiretroviral therapy in the setting of successful HIV virologic suppression, so it's not really a failure of antiretroviral therapy. In paradoxical iris, and hence the paradox, it actually may be seen in the setting of successful microbiologic clearance. So the imaginary TB patient that I mentioned may actually have at that point, or usually has at that point, negative TB cultures or even negative AFP smears. And the three major clinical predictors that have been described in numerous, both retrospective and prospective trials include severe CD4 lymphopenia at therapy initiation, the presence of an infection, opportunistic infection, even if it is subclinical, as I mentioned, as well as the shorter treatment of opportunistic infection prior to initiation of antiretroviral therapy, which is for the most part mandated by the current guidelines for very immunosuppressed patients, with a notable exception of cryptococcal meningitis. The pathogenesis of iris is not very clear. There's no clear animal model, so there are a lot of obstacles in both prevention, diagnosis, as well as targeted therapy. So we end up using the pretty unelegant choice of corticosteroids when we need to treat the patients, which, as you realize, is not really an optimal choice for people who are already immunocompromised. I just wanted to show you some examples that we have seen in the clinic, just to get, actually, let me ask, how many of you have actually seen cases of iris in the clinic? Okay, so I think I'm talking to a pretty educated and savvy audience. So I'm just going to go from the top left. This was a man who actually initially got diagnosed with HIV during pneumocystis, with the presentation of pneumocystis pneumonia, was started on antiretroviral therapy, and then developed this cervical necrotizing lymphadenopathy that was actually compressing his jugular vein and trachea, and this was all found to be secondary to unmasking Mycobacterium avium complex. This patient here on the right actually had disseminated histoplasmosis that was mostly involving his GI tract, and after initiation of antiretroviral therapy actually had small bowel obstruction and ended up actually requiring resection of part of the ileum, and this was all really secondary to granulomas with no viable histo at that point. And the last 3 pictures here at the bottom were from a patient who had miliary tuberculosis as well as TB, osteomyelitis, and arthritis, who developed really very severe iris after initiation of therapy with systemic symptoms, very high fevers, worsening of the arthritis that even required intra-articular corticosteroids, and then developed also a pleural effusion that was secondary to chylothorax from obstruction of the thoracic duct. All of them did very well, so there was a happy ending, but there was a lot of pain and effort in between. So moving to more specific related diseases, so iris really is very frequently associated with mycobacterial disease, both TB and non-tuberculous mycobacteria. Interestingly enough, about 2 to 3% of HIV seronegative people who just have tuberculosis have this sort of paradoxical reaction and an iris-like phenomenon when they start anti-TB therapy. Cryptococcal disease is another frequent infection, and actually can be fairly severe because it involves the CNS. It has been reported up to 50% of people with cryptococcal meningitis, higher antigen load, so positive blood cultures for crypto, positive CSF cultures when antiretroviral therapy is initiated are pretty significant risk factors. And then the management of the high intracranial pressure can be fairly crucial in the management of these patients. CMV retinitis usually is associated with uveitis upon ART initiation. Viral hepatitis also can, flares have been described. Herpes viruses can flare also with antiretroviral therapy, and pretty much any other infectious disease as well as tumors such as KS have been associated with worsening after antiretroviral therapy initiation. Specifically for TB, in different studies, the incidence has varied between 7 and 50%. Obviously, there is an association with timing of antiretroviral therapy, more common when therapy started early, as mandated by several randomized clinical trials. Usually happens between 2 and 6 weeks of antiretroviral therapy with a higher incidence in very low CD4 counts. The spectrum can be anything from exacerbation of the existing and initial disease, development of new manifestations or new sites, and dissemination or death. As we know, several randomized controlled trials in different places in the world have shown that delaying antiretroviral therapy in immunocompromised patients with tuberculosis is not optimal because it increases mortality and leads to other AIDS-defining illness. So the compromise is that people with TB have to start antiretroviral therapy when they have low CD4 counts within 2 weeks, knowing that they're going to have actually a higher risk of TB iris. So we'll be seeing more and more TB iris, I think, as the time goes by. And then finally, MDR TB has to be in the differential diagnosis, because I mentioned that the manifestations are worse. But to make things even more complicated, MDR TB can also be associated with iris. So it's not really, does not exclude the possibility of iris. This is a TB iris definition from the INCI, which is the International Network on Study in HIV-Associated Iris, and it pretty much covers what I told you before. So for TB, if you see new or enlarged lymph nodes, cold abscesses, or other focal tissue involvement, new or worsening radiological features, or CNS symptoms, or serositis, these could be all major clinical criteria for iris. And then the minor criteria are listed here, which are milder constitutional symptoms, respiratory symptoms, or abdominal pain. And the main really goal was here to try to avoid specific virologic or CD4 criteria in case these are not available in different places in the world. With respect to non-tuberculous mycobacteria, less work has been done here, but the incidence can vary greatly, between 3 and 30%. Usually presents with necrotizing lymphadenopathy, very much similar to tuberculosis, but also can have systemic symptoms. Overall, the prognosis is worse when there is intra-abdominal involvement, and we have some preliminary unpublished data showing that high alkaline phosphatase at baseline, as well as high C-reactive protein and D-dimer may be helpful in sort of predicting the development of MAC iris. INSI has also come up with a definition for cryptococcal iris. They require some antecedent criteria, which are known, obviously, cryptococcal infection that has already improved with antifungal treatment. This is for paradoxical and initiation of antiretroviral therapy. Clinical criteria, which basically include clinical deterioration within the first year of antiretroviral therapy with presentation with meningitis, intracranial lesions, skin lesions, or pulmonary nodules, or lymphadenopathy. And then what I always emphasize, exclusion of other diagnoses, including non-adherence. I think we just saw a very interesting case also of fluconazole resistance, and then other infection or malignancy. Just a quick reminder that the randomized controlled trial that was done to assess when antiretroviral therapy should be initiated in patients with cryptococcal meningitis showed actually that patients on deferred therapy, so after they have been pre-treated for cryptococcal meningitis for 2 to 4 weeks, tended to do better than the ones who were starting immediately within the first 2 weeks of initiation of a cryptococcal treatment. So this is one of the infections that we want to make sure that it has been under good control before initiating antiretroviral therapy. And these are also some data from cryptococcal meningitis showing that when the CSF is sterile at the initiation of antiretroviral therapy, there's a lower incidence of cryptococcal meningitis iris as opposed to when the CSF culture remains positive. And it tracks pretty well also the neurologic deterioration. So my take-home points for clinicians that I always try to teach our infectious disease fellows is to always keep in mind who is at high risk, because you want to be more vigilant and kind of try to be anticipating iris. So the patients at high risk are the ones who have very low CD4 count, very disseminated disease, which from the immunological perspective we call a high antigen load. So the people who have disseminated TB or extrapulmonary TB, or as I mentioned, positive blood cultures for crypto. Lack of immune responses in cryptococcal meningitis has also been linked to higher incidence of iris, as well as profound anemia, which has been found in some studies, and we're finding it in a study we're analyzing now at NIH. I cannot emphasize enough that this is a diagnosis of exclusion. I get irritated around when the first diagnosis that comes to mind is iris. These are very immunocompromised patients. You cannot afford to miss another opportunistic infection and blast them with corticosteroids when they have something else that you have not diagnosed. So I always emphasize that you need to do a pretty decent workup and feel confident that you're not missing another diagnosis. High CD4 count is not necessary, or high trajectory of CD4 count. We do see that people who have actually severe iris, perhaps because of they're so overloaded with inflammatory cytokines, may still have pretty low CD4 count when they present with iris. But for the most part, if you check an HIV viral load, it would be much lower than at the initiation of antiretroviral therapy. There's this concept in medicine of Occam's razor, or law of parsimony, saying that you need to come up with the simplest explanation for all the symptoms that you have. This is absolutely wrong in people who are very immunocompromised, and they can have as many diagnoses as they please. So in all the cases, you should always keep in mind that it could be something else. It could be iris. It could be iris plus. So they may have, we see people who come in and they have diarrhea and they have cryptosporidiosis and CMV colitis, and then they come up with pulmonary MAC iris, for example. And then finally, just as an infectious disease doctor, keep in mind that it's actually not an HIV exclusive phenomenon. So similar phenomena can be seen in other patients. We're seeing, for example, some bone marrow transplants now who may have some phenomenon similar to iris. I'm not just going to bother you about pathogenesis, but just to highlight that there is a very important role of T cells that are recognizing the underlying pathogen. These are CD4 T cells from this patient who had severe iris, as you can see here, from his axillary lymphadenopathy. And these T cells recognize the pathogen, the mycobacterial antigen, and they make tons of inflammatory cytokines. The same is true also for myeloid cells, such as monocytes. And we found that this is all data pre-antiretroviral therapy initiation, that classical monocytes that express CD14 and not CD16 have a very strong association with serum measured cytokines, such as C-reactive protein, IL-6, soluble tissue factor, and TNF. And our hope is that some of these inflammatory cytokines and markers could perhaps at some point be used as predictors or tools to be able to see who is going to develop iris. Moving to management, there's a very wide spectrum. Mild cases of iris, so you can feel comfortable just observing or following laboratory results or symptomatic relief. I think the important thing about cryptococcal meningitis is sterilizing the CSF. Non-steroid anti-inflammatory drugs can be used also for symptomatic relief. Corticosteroids for moderate to severe cases. Mechanical drainage really of lymph nodes is critical. We had cases with psoas abscesses that was necrotic material with no AFP left in there or no MAC left there, but the patients were really very in a lot of pain and could not walk, so we had to drain them. And then only rarely discontinuation of therapy is necessary. We pretty much never do it. We've done it only in the patient who had the histo bowel obstruction, and then he could not basically take anything by mouth after surgery, so unnecessarily he went on a short break. And then for prevention of unmasking iris, I think screening for opportunistic infections in immunocompromised patients prior to starting therapy, based on the prevalence of the infection in an area, either screening for tuberculosis or cryptococcus, might be very helpful. And these are some data actually showing how the survival improved after cryptococcal meningitis in Uganda when they were treating patients who had asymptomatic CRAG positivity versus symptomatic cryptococcal meningitis. So a simple measure that really even led to improvement in survival. Not much to discuss about therapeutic trials. The ones that have been done is corticosteroids in paradoxical TB iris. There was a randomized controlled trial in South Africa. They use corticosteroids in mild to severe cases. And they found that this sort of early usage of corticosteroids led to fewer hospitalization and procedures, but actually more infections and overall no change in mortality. Maraviroc was used in without any specific infection, but just patients with CD4 count less than 100 to prevent iris. The study enrolled 274 patients and showed absolutely no effect, no negative, no positive. It was really dead heat between the two treatment arms and did not reach statistical significance. Studies that are currently enrolling, there is a study with corticosteroids in TB for prevention that I think is fully enrolled, so maybe results will be available soon. And then there's a study of sertraline in cryptococcal meningitis that is going to be very interesting. There was a pilot that enrolled several patients and has already been published in Lancet ID that actually showed very quick clearance of cryptococcus with the addition of sertraline, and actually very, very low incidence of cryptococcal meningitis iris. So I think it will be very interesting to see the results of this study. So what I showed you is that, in combination with my talk this morning, that opportunistic infections remain a reality in regions with high prevalence of HIV. Iris is an inflammatory reaction that can be managed for the most part with maintenance of antiretroviral therapy, but may require additional immunosuppression. Management of immunosuppressed HIV patients should include screening for opportunistic infections. There's a prominent role of monocytes and T cells in production of inflammatory mediators in iris. And then these inflammatory biomarkers might eventually be important predictors. And we're looking specifically at the potential role for IL-6 and C-reactive protein in early diagnosis, and also as potential therapeutic targets. I think in the interest of time, maybe I'll move to the cases, and then if there's time, we can do questions. That's okay? Yeah. Okay. So the first case, not your usual hiccups. This was a 38-year-old man, originally from Sierra Leone, but has been in the US for several years, and initially presented with persistent hiccups, anemia, and he was found to be HIV positive. He also had thrush, weight loss, chills, fatigue, cough. CD4 was 10 and viral load 350,000. He had a bronchoalveolar lavage that was positive for AFP, but the culture grew MAC, and he had negative blood cultures for MAC. He was started on azithromycin and ethambutol and clinically improved, and the hiccups also improved. Subsequently, he was started on antiretroviral therapy with Stribild, which is an elvitegravir drug. And then 2 weeks later, he came back with really severe hiccups. He couldn't even sleep. His CD4 count had increased to 63. Viral load had dropped to 237. C-reactive protein had gone to 51. And then we tried to sort of conservatively manage him. And then 4 weeks later, came back now with systemic symptoms, fevers to 40, 41. Even more severe hiccups. C-reactive protein now had gone to 120, CD4 to 163, and he was also quantiferon negative. Prior to ART, he was indeterminate. We did a repeat chest CT. On top is the CT prior to antiretroviral therapy initiation. He had some very small pulmonary nodules, and now you see that they are larger, and there is also cavitation. And this is the C-reactive protein that, as I told you, had gone way above 100. So let me see if I can do this. Nope. Okay, great. So what would you do? Would you start corticosteroids immediately and no further workup necessary? Would you repeat bronchoscopy to exclude other diagnoses or progressing MAC? Would you add moxifloxacin into his regimen, or B and C could be considered together? In reality, there are 2 correct answers. All right, very good. That's fantastic. I think we're done. Okay, great. So I think I convinced you that you should never start corticosteroids blindly, which is great. So we did repeat bronchoscopy. His cultures were negative. But the problem with these cultures is that they do take a long time, and there are cases where you may have resistance to macrolides. So in that case, we did add moxifloxacin just to make sure that we're not missing that situation. So we're completely in agreement. Oops. Okay. The second case, is it the drugs or the virus? This was a 30-year-old man. He initially presented with some skin lesions, went to a dermatologist. He diagnosed him with KS. That led to his HIV diagnosis, and at the time of diagnosis, CD4 was 7. He was hepatitis A antibody negative, C negative, and RNA including C negative, and then he was found to be positive for hepatitis B surface antigen, as well as E antigen and C antibody. He had no really other infections or OIs, and the KS did not require any additional therapy other than antiretroviral therapy, so he got started on a tripla as well as Bacterial and azithromycin for prophylaxis. And we also gave him a hepatitis A vaccine. So I'm showing you a little bit his data. I guess ALT is as GPT, and AST is as GOT. And so this was his hepatitis B viral load when he got started, as well as his CD4 and HIV viral load. And this was his trajectory. So a couple of months later, he starts really spiking his liver function test that went close to 1,000. And as you see, he had a very good response overall as far as virologic suppression with HIV, but also virologic suppression for hepatitis B. So the question you have to, oops. Okay, so which of the following is not true? It is unclear if this is iris or hepatitis B flare secondary to immune restoration disease, as it could represent also drug toxicity. He was on Bactrim and efavirenz also. So flares of hepatitis B during antiretroviral therapy may be serious and even lead to hepatic failure. Higher HBV viral load may have predisposed to this flare. And then finally, flare as iris leads to lower rates of suppression and seroconversion. Very good. All right, great, fantastic. So this is also true. Oops. Good. So what happened here is we actually stopped his atripla and we switched him to a raltegravir regimen, but we also stopped his azithromycin and his Bactrim. And despite stopping those, as you saw, the LFTs actually peaked after we had changed his regimen and we had stopped the drugs that perhaps could have caused the toxicity. So hepatic flares are not unusual after antiretroviral therapy initiation. Thankfully now they're less common with less use of nevirapine and some of the other drugs. But they can, there has been an association, again, it's the antigen load. They have, the ones who have higher hepatitis B or C viral load, they seem to be more at risk to flare once antiretroviral therapy is initiated. There seem to be also some immunologic correlations with higher levels of interleukin 10, 18, and CXCL10. Fatalities actually have been reported from hepatic failure. It can occur in patients who are even just hepatitis B, C antibody positive. The incidence can be as high as 20%. Really, it's a very tricky diagnosis because of the differential diagnosis with drug toxicity. And, but actually, it does not affect clearance. And if anything, in some cases, it may increase clearance. And in his case, actually, he did convert to E negative. Okay, the next case is a 33-year-old African woman who presented initially to the hospital with right upper lobe infiltrate and mediastinal lymphadenopathy and was diagnosed with TB. As soon as she got diagnosed with TB, they did an HIV test and her CD4 was 10. And she was also found to have an HIV RNA of 1.1 million copies per ml. She was also B positive, but it's completely irrelevant in this case, just giving you a clue. She was started on a tripla, RIPE, as well as Bactrim. She actually had DRESS syndrome from rifampin, so we ended up taking her off rifampin. And so when she was eventually referred to us to enroll in my protocol, she ended up on a maintenance regimen instead of INH and rifampin on INH, ethambutol, and moxifloxacin. She was doing great, clinically improved. CD4 was 84, viral load had suppressed to less than 40, but then she complained of blurry vision. And we found this on physical exam. Okay, very good. And even when she fixated her stare, as we're doing now, she still had it. Ugh, I don't know how to stop the video. Okay, good. Okay, so you would do an MRI, call a neurologist, call an ophthalmologist, stop ethambutol, repeat CT of the chest. Oh, yes, sorry. Rats. So anybody wants to say about the finding? To yell it or no? So I heard nystagmus. You want to be more specific? Okay, fantastic. So this was fast-beating vertical nystagmus, which is almost guaranteed to be a CNS problem. And she had actually no dizziness. She had no, other symptoms to make you think that there was something in the labyrinth or the ear or anything. So it was clearly a CNS issue. And sure enough, oops. We did an MRI. Now, interestingly, she had an MRI a couple of months before because she had really intense nausea that had been read as completely normal. Now, of course, in retrospect, there was a 1 millimeter lesion there in the medulla. And now it had become 6 millimeters. And it was really a button lesion that all it was causing was just this nystagmus. Now, the issue with CNS disorders after CNS issues after starting antiretroviral therapy, this is a study from South Africa, basically showed that CNS tuberculosis was usually the most common etiology, but of course it could be cryptococcal meningitis, intracerebral space occupying lesions other than tuberculoma and psychosis. And iris was diagnosed in about 28% of these patients that was related to TB and some in cryptococcosis. So in her case, since she did have that lesion before, we suspected that this was a tuberculoma. We did an LP. Everything was pretty much negative. And we decided to add prednisone as well as linezolid that has very good CNS penetration, in contrast to, let's say, INH and ethambutol that have really very poor CNS penetration. And it literally melted away within a couple of weeks. It was back to the 1 millimeter lesion that I showed you before. But her nystagmus actually persisted for much longer. Okay, the fourth case, when something doesn't feel right, it usually isn't. So this was also an African woman, initially presenting with neck swelling and lymphadenopathy. She was diagnosed with TB that led to the diagnosis of HIV. Her CD4 was 6. Her HIV RNA was close to 1 million. And in my protocol, we screen all the MSM or women from Africa for KS at baseline, KS herpes virus by PCR, and she was PCR positive but had no really signs of KS or any lesions. So she was started also on a tripla ripen Bactrim. Very quickly after initiation of therapy, she developed fevers, necrotizing tendral lymphadenopathy, and her CD4 increased very quickly to 70 and viral load suppressed to 6,700. So after a very decent workup, her drainages were all negative both by AFP and culture. She was initiated on prednisone for TB iris, had some initial improvement, but then started being admitted a couple of times with persistent fevers and very severe anemia that actually required transfusions, despite high-dose prednisone and large volume drainage of her lesions. So this was actually her initial sort of lymphadenopathy. She had occipital and cervical, and it was kind of all over the place. And this is how it started becoming after she presented with symptoms of iris. You can see here how she has multiple loculated cervical lymph nodes with necrotizing material. We kept really the ENT surgeons pretty busy draining her, but she also had this huge ileopsoas abscess that required a few drainages. But despite draining and despite the prednisone, she was really not improving. And this is a course of her hemoglobin. You see it was 7, then transfused her, then dropped to almost 6, then we transfused her, then again dropping to 6, in combination with fevers and C-reactive protein that was above the upper limit of the assay. So it was being reported as more than 250, basically. So in her case, which of the following is least likely to help with diagnosis and management? Repeat drainage with mycobacterial stains and cultures. Consider other diagnoses that are associated with severe anemia and lymphadenopathy. Pursue a lymph node or bone marrow biopsy to evaluate histology better. Fever and anemia could be a drug toxicity and Bactrim should be stopped. Increased immunosuppression, higher doses of corticosteroids or other should be started. All right, great. That was very soft, I think. All right. So this is very true. When it feels that something is off, you should really look for other things. And we definitely had the bug because she had also the KS herpes virus PCR that was positive. And we have seen before, it was, in both cases that I've seen, at least it was women from Africa where they would really flare KS after we started steroids for TB iris. So we're looking for it, but there was no case to be KS to be found. Then we realized that her anemia was actually Coombs positive hemolysis, so that really made us start worrying about her. So we ended up doing a lymph node biopsy and in the non-necrotic lymph nodes, and what she actually had was Castleman's disease. So that's one of the tumors that can, or one of the manifestations of Kaposi sarcoma in the spectrum that you can get, and it's really induced by viral IL-6. So we had the IL-6 from her TB iris, and we had the viral IL-6 combination, and we're very lucky and fortunate that there was an experimental protocol at the National Cancer Institute with use of tocilizumab, which is an anti-IL-6 receptor, specifically for Castleman's disease. So she actually received that, and it worked fantastically for both her TB iris and her Castleman. So she's doing great now, and she's trying to plan her first pregnancy. So the last case that I have, the question is whether we can consent him. This was a patient who was I got called when I had opened my most recent IRIS protocol, and they wanted to send him to me, and I was wondering if he would be consentable basically when he arrived to us. So he was 48 years old. He had already been on therapy for 3 months. He had started antiretroviral therapy with a CD4 of 11 and with cryptococcal disease, both pulmonary and meningitis. He had been treated with amphotericin and flucytosine for 2 weeks, and then he had been started on a tripla. At the point that, at the 3-month time point, CD4 had increased to 117, viral load was suppressed, and he had acute onset fevers, headaches, and mental status changes. Amphotericin was restarted. He had a lumbar puncture with an opening pressure of 38, white count of 312, protein 285, and glucose 18. His CSF culture was no growth, and his chest CT actually showed decrease in pulmonary nodule. That was secondary to crypto when he initially presented. But he was encephalopathic and not responsive. This was his MRI. And so next step in management should be brain biopsy, large volume lumbar puncture, and initiation of corticosteroids, initiation of sertraline, or initiation of toxoplasma treatment, and repeat MRI in 2 weeks. Okay, lovely. Okay, so this is exactly right. So this is, I think, a pretty classic case of cryptococcal meningitis iris. So he required actually multiple LPs to drain and bring down the intracranial pressure. All the fluid was always negative by culture, but there was cryptocin in cytopath, and he required a very, very, very slow taper of prednisone, and he's doing actually great now. Very good. So that's it. Thank you very much.
Thank you very much, Dr. Sereti. Any questions for Dr. Sereti from the audience? Please go ahead.
Hello. Thank you so much for the presentation. Just one question about mortality in general, because I found the range 7 to 50, it's really a big one. And I wonder, it's a bit complicated question because it's going into the test and treat where we are going, especially I'm talking about developing country with no CD4 count.
Yes.
I agree that the clinical sign for iris that's supposed to be the one referring or to, I don't know, keep an eye, but to if there is any other way on which with limited resources available, with the fact that we see all during these days about start early treatment,
yes,
and mortality, where is the balance between the two?
Right. So I think the scary part in missing something would be starting therapy when someone has already cryptomeningitis. So I think that's certainly an issue. But, and you have to answer my question. So isn't it possible to have a same-day result for cryptoantigen? Or no, not even CD4 test or anything, yeah. So I would think that in the large scheme of things, probably that will be something that's not, considering how many lives you're gonna save, hopefully once you get the CD4 back, and hopefully maybe you have requested a cryptoantigen if the CD4 is low, It may not be, if you're expecting it, it's not as bad as if you're not expecting it, is all I'm trying to say. Now, specifically for mortality, we have done a study actually here in Thailand, NIH, and Kenya, and we have found that people who develop iris versus those who do not develop iris have exactly the same mortality. So having iris does not protect you from mortality, but does not also make it worse. Personally, I am very wary of CNS iris because it's certainly a tricky thing. But I think if the physicians are savvy and they're sort of expecting that possibility, particularly with crypto or TB, hopefully they can react quickly. My only worry is those patients who live far away from medical centers and they may not have good access to care. I mean, we're really very hawkishly following our patients, and we send taxis when they don't feel well, to bring them to the clinic, which is, completely not the real world situation. So, so I suspect in the big scheme of things, it's probably a small wrinkle.
Any more questions? Please go ahead.
I have a question more on the basic biology of iris.
Mm-hmm.
So,
I try to avoid discussing it.
sorry.
No, that's fine.
So, what do you think happened to the CD4 Treg during iris? Because it seems like it's of course not doing its job during immune reconstitution.
Right. So the elusive role of Treg. So they're there. So as far as phenotypic Tregs, they are there at the same proportion and at the same numbers as we see in people who do not develop iris. When we try to address their function, it's not exactly an easy thing to do, considering the lymphopenia of these patients. But when at least we try to see whether they act as effectors as opposed to not making cytokines, whether they actually do make cytokines, they don't. Because it has been described that in highly inflammatory states, they can gain sort of Tbet and then act as Th1 cells, for example. So they don't seem to be doing that. Now, in theory, you could argue that they should be higher than in the patients who don't develop iris, but we don't know. We are not done with Tregs. Now we have some lymph nodes from patients with iris, so we'll try to see also if in the lymph node, if they're absent or they're not sort of connecting appropriately with the effector cells and such. So we don't know. We don't have any striking evidence that there might be something wrong with them, but it's still an ongoing thing.
Thank you. Any more questions? I think that's it. Thank you very much, Dr. Irini Sereti. I would like to express our gratitude on behalf of the HIV-NAT Symposium staff for all of you who stayed here. I know it's been a long day, and we still have one more day of the conference left tomorrow, and see you tomorrow. Enjoy the rest of your afternoon. Thank you.